All right, so hello again. Welcome everyone. Happy Thursday to you all. We've almost made it to Friday and hopefully have a lovely weekend ahead. So it looks like we've got a decent cohort here, so I'm going to go ahead and get started. For those of you who haven't attended one of these sessions yet or that don't know me, my name is Christiana Letterman. I'm the Director of Alumni Relations and Individual Giving here at the Tulane School of Social Work. I'm so pleased to welcome you all to our May session in the 2021 Alumni Lunch and Learn series. These Lunch and Learn sessions are a new initiative that we've created to provide free continuing education credits to our school's alumni base. And I'm really excited to be able to offer 4 of these to you every single year. So our next session after this will be coming up in July with Dr. Samuel Bradley Jr. of Boston College. And I'll send out more information to you next month so you can all plan for that. Also, a quick note about certificates today. I put those together and I'll be sending those out in the next couple weeks based on the email that you're attending with today. So please be a little patient with me as I get those together for you. Just to note that your certificate will be based on your time in session that is recorded by the platform. So I know most of you are really familiar with Zoom, so much so probably that you can do it in your sleep. But for those of you who don't use it that often or need a refresher, as we go through the session today, please use the question function if you have any questions related to content for our facilitator. And we're also going to try to use the raise the hand function today. So if you verbally want to ask your question, click on the raise the hand button, and we're going to enable your audio so we can all hear you. Otherwise, you can use the chat function to communicate with myself or the other moderator, who is Carrie Mulder. And if you need any support or have issues with the platform or questions that aren't about content, you can put all of that there. Just another note, this session will be recorded and posted to YouTube following today. So please be conscious of not sharing details that would identify your clients or any agencies you work with as you ask those questions. All right. So now with the housekeeping out of the way, welcome again, everyone. You're joining us today for Ethical Case Studies in Tele-Mental Health, which is an overview of telemental health basic standards as required by licenses. Our wonderful facilitator is Parker Robinson, who serves as the Tulane School of Social Work's Director of the Porter-Cason Institute and Center for Lifelong Learning. She is also a fellow alum from Tulane and has been working with us since 2009. She additionally works in private, clinical, agency, and community macro settings. So Parker, thank you again for being with us today. The screen is all yours.
Great. Hi, everybody. It's so good we have such a good alumni turnout. You know, this is family, and it's so good to be with family again. The way we do things in Center for Lifelong Learning, the events that we think are most important for us to step into are those. I mean, we love to step into any event and provide education, but we started when I first came on board. It was, you know, after Katrina, a couple years after Katrina, and we were having all these issues around families, addiction, trauma, interpersonal violence, and so because I was in the Porter-Cason Institute and in doing the Center for Lifelong Learning, I was getting all of you and also the rest of our community coming and saying, hey, what are we going to do? We need an evidence-based practice to step up our game with these relationships. And so we literally went out and got one and brought it back and created a community which was looking at each other's work and supporting each other and very open about it. So that became our model for all of our Center for Lifelong Learning work, is that we look to present evidence-based models, but we also really honor the part that is about community experience and all of our collective wisdom about what's going on. So this telehealth effort that we've had going for 2 years has been, well, last spring and this spring, has really been about that, coming together in rapid change and really facilitating us all doing our best work using telehealth during a very kind of stressful time for our clients and for us. So we've had a wonderful experience with that and have learned so much from the community and have been able to bring some information as it becomes available that we get a hold of. And it's been a wonderful dialogue. So I'm hoping that's kind of what it's like today. I know this is a little bit different format for people who come to the CEUs today. It's a little more formal. We're raising hands. We're doing that kind of thing. But please know you are totally invited to jump in. Your wisdom, we can learn from it. So we can all learn from it. So please do that. I know that Carrie's going to start with a poll about who is actually using telehealth now and who is not. So let's see what we get from that. If y'all don't mind answering it. Just hit the button and submit it. And while we're waiting for the results, I'm going to tell you that one of the best practices in telehealth, very specific practices, is that you have a contingency plan if your technology goes out. So we're going to do that today. If my technology goes out, we've had a lot of wind and a little bit of unstable internet connection. If mine goes out, what I'm going to do is I'm going to take my personal hotspot and try and connect back to Zoom. That usually works 90% of the time. And if that fails, then I will be in touch with the moderators about our next steps. And it may mean that I am going to do the Zoom on my phone directly. We'll see. But anyway, just that's what we always do with our clients, because it's a bad thing to be in the middle of a session and not have a contingency plan if that happens. And it does happen. So this is interesting, right? So 41% are saying no, they're not using it right now. And 59% are saying that they are. So we all have experience with that. And we all have experience with how we've had to shift our practices to use it more. So now I'm going to share my screen and I'm going to put my slides up. And I'm going to, okay, there we go. So we have gone through a period of very rapid change, and it is rapidly changing again. So I'm not going to go with you all of the specific criteria, like make sure you have an identification for the client if you haven't seen them before. I'm going to give you some of that, but we have a short time together, and our series in telehealth is 10 hours. So I'm going to hit the high notes. But what I am going to focus on today is, with this rapid change, how do we continue to keep the best interests of our client in mind, and how do we keep them in conversation when we may be running agencies or having private practice? We come from different practice settings now as we're moving sort of back to a more normal continuum. But we've had this experience with telehealth. We may start looking at hybrid changes. So we need to think that through with our clients in mind and really take serious which clients are best for using telehealth and which ones may not be as optimal choices. And so when we finish kind of going through these basic slides, we're going to look at 3 cases that have actually come up from my client base, but also from these very rich conversations with the practice community, including licensed professional counselors, because we wanted to include all of the mental health professionals together. And so we'll be kind of thinking through those and talking about them. And I look forward to anything you all might add in terms of your similar experiences or questions. So this is CDC data as of 2021 with the health center programs that the federal health centers. 43% of health centers were capable of providing telemedicine in 19, and in now during the pandemic that went up to 95%. So, some of us were doing telehealth. Remember, this is just health centers. This isn't everybody. This is just the CDC data. And I did put the connection to the website up above it. And the importance of this in the conversation we're having today is some of us were using this prior to COVID. I was using this prior to COVID because I had a sort of a community of Bayou clients that we would do kind of a hybrid. Sometimes we would do online, sometimes we would not. I have a private practice software called Simple Practice, which has end-to-end encrypted ability. So it's HIPAA compliant. And I was able to do that with my clients when they couldn't come up here. So there were other people like that. When telehealth first started, it was kind of an answer. And if you look at the literature, it was kind of an answer for rural areas, for Veterans Administration, for some underserved populations in order to get better options for different populations to have access. But now we have so many people using it that really, I think, we really have to think through, there are evidence-based procedures, and in this state, LPCs are required to adhere to very specific standards, which are best practices. So we should be doing them too. And we're going to talk a little bit about how our board words things versus the LPCs. So here's another one. The number of, this was done in 2018. The number of telehealth consultations estimated around 160 million cases by 2020. Well, that was, prior to COVID. So 18% of consumers have used this type of service, and telehealth has yet to become the go-to place for care. That was Huron Consulting in 2018. This is another consideration, general consideration, while we're moving back to a hybrid model. And your agency is going to have to think through, are we going all back to person? Are we going to do a hybrid with some telehealth? What parts are we going to do? How are we going to develop protocols around those parts? Because our clients, first time out for them, and they wouldn't necessarily know what the standard is in terms of HIPAA compliance and sort of clinical criteria for selection and those kinds of things. So we really have to think through this because it's their first time out too. And it may look to them like, oh, we just get online and we talk. Well, there are all kinds of things, as we know, with our licensure requirements that need to be accounted for. Remembering that telehealth is not a form of therapy, it is a delivery mechanism for the therapy you are qualified to do or the services you are qualified to provide. So this is Kaiser Permanente, and I love looking at their data from time to time because they are what we call a closed healthcare system, which means the insurance product and the actual healthcare delivery are together. So they've got complete data of services, what they're paying for things, and also what the provider side of it is. So you can see what's going on here, that 58% we're already receiving some encounters with system virtually, and I'm sure that's up. And interesting, and I don't have it here, but I was looking at some data the other day about something like 95% in some system, and I can't quote it right now, but 95% of psychiatry visits. Oh, it was a Wall Street Journal thing where they had gotten a hold of some data, but I can't remember whose it was. That the top of the list in terms of services, one of the top things is psychiatry, which is another thing that we're going to have to, really partner with and get our communication better with the psychiatrists that we partner with. I see some very traumatized people and multiple mental health issues. And, if you're a psychiatrist, and I have friends that I work with with a lot of these clients, if you're a psychiatrist and you're seeing a client every 15 minutes versus on a Zoom, are you really getting all the information? It's no different than before, although now it's, you're not even seeing the client in person. So you really might be missing things. And I've had a couple situations where I've really had to go back to a psychiatrist and say, hey, I know she told you that she's not getting psychotic, but she is. And, with releases, of course, but, it's really important to consider what your relationships are with psychiatry if you need those relationships. So what we're going to cover today is high-level overview of a fixed statement, including, can you all hear me? Are you hearing me?
Parker, you may want to go back to the beginning of this slide. You did freeze for a moment.
Okay.
So if you want to go back to what we'll cover today and just.
Yeah. Okay, great. Thank you. Let me know if that happens, just so I know where we are. The wind is howling over here. So the Louisiana State Board of Social Work Examiners and LPC in this state are equivalent in terms of, the need to be doing evidence-based practices. The statements in our regulations are much more general than the statements in theirs. Theirs are really, really specific to the best evidence-based practices. And they require 10 hours, which is what we're providing. We have actually developed the 10-hour series that we do during the spring. We did it last spring. We're in session 8 this spring so that we can provide our LPC friends as well as our own LCSW and other social workers the same free providing services with evidence-based practice. We just felt like that was a really important thing to be able to pivot into. So we're going to do a COVID update, and we're going to talk a little bit about the 10-hour training series, high-level discussion about practice operations and considerations, and the impact of the new CDC guidelines, an important checklist for you and your client prior to the first meeting, and a discussion of 3 case studies from the last year and a half. So this is what happened last year, and I'm sure some of you guys are familiar with this because you've been trying to figure out all along, what am I required to do? What am I not required to do? And the governor came in last March and said, hey, COVID's here. He threw a bunch of stuff into a law, and one of those things was telehealth. And then he authorized the use of telehealth, all these other things. So we're kind of in this, at that point, we're kind of in this place where everything was kind of relaxed. I was talking to people who were, even though it's not best practices, who were having phone sessions with clients until they could get together their model. And, you know, there were all kinds of things going on. And there was a little bit of relaxing of best practices. We, in social work, are even allowed to supervise online right now until June. I know some of you supervise, and I haven't heard the update about that, although I have a state board meeting this afternoon and a subcommittee, and I'm going to ask. But, you know, there were all these things that just got relaxed that had been talked about for years, and then all of a sudden there was just this rapid change. And so with that rapid change, we kind of downgraded maybe quality, or maybe, you know, just some things we weren't thinking about so clearly, and everybody was doing these new things. So now that we've kind of moved through that, we've seen some of the issues that come up, and they'll come up in our case studies today. And we're moving back to making decisions about what is our hybrid going to look like, or are we going back to our old practice models? So this is what happened last week. So we got the word from the CDC, and then the governor came out and said, regarding face coverings, there's a CDC guidance update, and this is what the governor said. Fully vaccinated people no longer need to wear a mask or physically distance except in limited situations: mass transit, healthcare facilities, and correctional institutions. And here's where we are with the vaccinations in Louisiana. So, you know, as of last week, you can see that out of a population of 4.56 million. So with the vaccinations and with people who have already had COVID, yes, we do have quite a significant population who now has some form of immunity. And the governor kind of left it up to jurisdictions to kind of talk about, you know, where we are with local guidelines, but this was his statement. So this was a couple of weeks ago, which was super interesting. Louisiana's vaccination rate has lagged the nation in recent weeks, with 32% of its population having initiated the vaccine series, compared to a countrywide average of 42. The good news is Louisiana is doing better than most states in controlling the spread of the virus, ranked at the bottom third of all states for new cases. And we're also in the top states who have vaccinated underserved populations, that there's been less disparity here than in other states. So that's the good news, you know. And again, you know, as we've had these two series of telehealth series, we have really emphasized how we can make sure that people, you know, in those groups, and we get from, you know, 175 to 300 people every week, licensed professionals in those sessions. And we really, really focus on what do we need to be doing this week, and what do we need to be doing in general to kind of help our clients move to this place of safety. So here is, you know, when we were first grappling with, well, what the heck does this mean to us, right? And this was last year. Labs, we put out the statement that they recognize that face-to-face contact for the purpose of providing services is optimal. I'm not sure I agree that it isn't equal in some cases, but this was a statement that was made last year, but that it is not always possible. The Louisiana Social Work Practice Act and Rules, Standards, and Procedures do not include requirements specific to telemental health. The same statutes and rules that apply to in-person services applies to services being provided through electronic means. It is the responsibility of the social worker to practice within their scope and to assess whether telemental health is an appropriate service for a particular client. So that's kind of how our guidance is. If a client is in another state, It is recommended that you contact that state licensure board to determine if licensing is required in that state to provide services to the client. ASWB, which you guys may not be familiar with, but you may be familiar with, it's the group that does the licensure test. It's also the group that is the conglomeration of the social work boards. Also has technology standards that that Louisiana Board of Social Worker Examiners refers you to. And if you look at that and you look at the LPC specific requirements in this state, they are the same. So this is usually the part before we get going. I don't know if there are any questions or about interstate practice, but we usually get a few. Does anybody have any? No, okay.
I see, yes. Hi, Parker. I see one. I have Deborah who just raised her hand.
Hey, Deborah.
So Deborah, you would need to unmute yourself.
Hit unmute. Is it unmuted?
Yes,
Okay.
you're good.
Hey, Parker, it's Debbie. If I go on vacation this summer, can I continue my telehealth with my clients here in town?
You can, as long as your clients are here and you check with the board there. I mean, the guidance from Lab Suite is make sure you're in compliance with the state that you're in or your client is in.
Okay,
Hey,
that's fine.
sorry, I'm
Thank you.
multitasking over here.
I can take that away.
Is there anybody else, Carrie, at this point?
No,
Okay.
that's it. We just had the one question. Yes.
Awesome.
So you can move forward.
And Debbie Pointevent, one of the stars of our Alumni Association. I was so happy to be able to train under her and learn so much from her. So she's a treasure to our Alumni Association. Okay, so the ASWB, the Association of Social Work Boards, in the fall of 2020 said, hey, we need to get a hold of where we are, what the guidance is coming from each of the state licensure boards and where it is. And so they actually did a study last fall. And to me, it was so revealing and kind of very similar to our experience here, which was we had to kind of scramble to see, all these different guidances from friends, from our ability friends, from,
All it looks like
food provisions in the telehealth.
Parker, it's Carrie again. When you started screen sharing, it sort of cut out. So you might want to start again from this slide. Yep.
Perfect. Sorry, y'all. I really apologize. The wind is howling. I feel like I'm a pioneer again. Can you hear me, Carrie?
Yes, and we can see your screen again. Yes, we are good.
Okay, good.
Thank you.
Good. Guidance around telehealth. And this is what they found, which I just found so interesting, that it's in different places. So you've got to look. I had a client in Georgia. Well, she was going to school in Georgia and there was an emergency and mama asked if I could see her, and I had to, and I know other people who I've talked to during these sessions have had the same experience. It was hard to figure out where that state had their regulations or statements on what we can and can't do. So they're kind of in different places in different states. So 9 states include provisions in the regulations. 8 states and 2 provinces have exclusively adopted formal policy statements. 6 states have provisions both in statute and regulation. 5 provinces, because remember, ASWB also covers some places in Canada, have provisions in practice standards. 4 states have provisions in statutes. 2 states have provisions in both regulation and practice standards. So you can just see there is just a variety in where people are putting their guidance on telehealth. And here's some more, and you can look at these later.
Parker, if you don't mind, we've got a question in the Q&A.
Sure.
From Paula. They ask, can you conduct a telehealth session with your client if you are here in Louisiana, but your client resides in Louisiana, but is on vacation in another state? So it's kind of like the flip of what Debbie was asking. So you are here in Louisiana, your client resides in Louisiana, but is on vacation in another state.
Right. Our board requires that you're in compliance with both states' guidance. So the place where the client is considered the practice site, technically. So it just depends. And, you know, part of that too is one of the evidence-based practices and procedures that we have in telehealth is that we need to know if there's a follow-up, I don't blame you.
There is, Janet had a follow-up to that. By compliance, do you mean licensed in that state? Oh, Parker, I think.
Some states allow us to practice in their states if it's a telehealth case, and some states don't. And so they have different, you know, guidance on that. So before you do it, you have to know what that guidance is and if you're in compliance. When I was working with my client who was in Georgia, I had to refer her to another mental health professional because it wasn't clear that they were going to be okay with me checking in with her there.
And then one more follow-up. This is from Louisa. How do you find which states allow and do not allow you to practice in their state?
I think you can see on ASWB, but I started there when I was looking for Georgia, and I had to go to Georgia's state social work board. You know, you have to kind of think through what states are you talking about and go there. ASWB can kind of point you in the direction in many cases, but specific information, sometimes you just have to go to the state regs. So that's always a big topic. You know, I wish and I think we will have clearer guidance about that. And I think it's a real issue too, because we have so many people doing telemental health now and telehealth, and we've got counselors, we've got coaches, we've got unison, but, you know, states have jurisdiction. Hold on. Can you guys hear me? Okay. So technology must support the ethical requirements of the structure of your practice. So our ethical requirements have not changed just because we're doing practice online. And when you consider that, you have to think about the structure of your practice. My first master's is a master's in business in health administration, where that's all I did was think about the operations of delivering healthcare. And it's really important to think about, what is the structure of your agency? What are your policies? What are your protocols? What kind of inventory of delivery systems do you have? What types of professionals do you work with? What are the specific activities in your practice? And how are you going to think about that in terms of keeping your ethics together? I supervise, I do supervise students, but I also supervise LMSWs working on their LCSW. And it has been during this year, and I'm sure some of you could comment on this, and I hope you do, that policies and agencies haven't quite caught up to some of the nuances of how we're going to practice safely doing telehealth, especially where it comes to HIPAA. In other words, you know, I'm now in my living room, which is not where I see clients. I see clients in an office in a house in the back of my house. And if you're an agency and all of a sudden you've got to make sure that all of your counselors or all of your case managers are working from home and there's HIPAA compliance, what kind of policies do you have in place, and how do you make sure that you don't have people running in and out of places in the home? So there's a whole lot that goes on to that structure piece. So, you know, then when we were changing into this COVID place, how did that change operations in your agency or in your practice? And then, you know, what were the new assessments and forms? I've always shared, and I will share again, the simple practice forms that I have. I think they're really good ones around telehealth. And, you know, I have learned to be much more three-dimensional in my assessment practices during this COVID crisis because of some lessons I have learned the hard way during it. And then, you know, as we're moving again, because we moved into a crisis and now we're kind of moving a little bit out of it, what are the implications and what have you learned in your practice? What have we learned together? What has the agency learned? And how are we going forward with a hybrid model? If we're going forward with a hybrid model, what will that look like? And what will policies and procedures and all of that look like? And what does billing look like? What does, you know, we've heard during telehealth that the insurers are not on the same page with this. And that, you know, our community has reported back to us that Aetna may, or any of the providers, I don't want to pick on Aetna, may say, yeah, it's included in this plan, but it's not included in that plan. So, you know, that's a part of the model that you need to consider. If through digital trust and safety, which is treatment environments, you know, one of my favorite sessions this summer, and also we talked about it again last week in session 7 in telehealth, is this last summer, I was working with the school system here in New Orleans and with the charter school system around their counselors around what they were doing and best practices in telehealth. And what came up, which I had never considered, and it's kind of a cultural thing in Louisiana, well, certainly in New Orleans, is if you've got a kid in a shotgun house, you know, how do you ensure confidentiality in that house, and what do you do about that? So treatment environments really came alive, and have come alive in my private clients. But in that sense, you know, we got these houses here that, and you know, in my own practice, I was seeing a guy last year who had a history of suicide ideation, had a very small house. And he didn't really want his children to hear our sessions, which I was very happy about because that would be unethical. And so he said, well, I can go sit in my car. Well, one of the things that we make sure of, one of the ethical standards is the evidence-based procedures is that we know where the person is. So, I could totally recognize when he was in his own driveway, but then, he pulled out and went somewhere else in one session, not while we were talking, but when I came on my telehealth, he was in between business appointments and he was in a parking lot. And I made him I already had the license on the back of his car, but I made him get out and show me, the street crossing so I could identify where he was. He wasn't in a suicidal mode at that point, but, keeping in mind the safety of a client who isn't in your own office, you got to know where that client is when you're talking to EMS, and you got to know which EMS you're talking to. In that case, it was Jefferson Parish and not New Orleans. So assessments have got to be more than flat paperwork and flat interviewing, because it's really going to be a conversation that involves educating clients and empowering clients around what is optimal for them. We are moving out of this, everybody has to do it the same way now, back into a mode where we're going to be getting probably tightened up with evidence-based practices and who are the best clients for this. And, I learned the hard way. I'm not ashamed to say it, that I was we've all been so busy, and we've probably all been overwhelmed with our clients, a lot of them, and students, and whatever we have going on as social workers. And this year, I had a client who I took on who was post-hospitalization for suicide ideation. I had her history. She came in because, for me, in that kind of situation, I want to see them in office first. And I do have an office that is alone where we can socially distance with masks. So I was able to see these clients and kind of assess what was, in person. So she presented in office as, very depressed, but, pretty on the ball. I did mental status. She seemed pretty together. Her thoughts were pretty together. So I said, okay, she is a client that lives an hour away. I said, given your medications and everything, and given that we have a safe environment for you, because her mom was going to be in the house, and we'll talk a little bit about that. But her mom was going to be in the house during our sessions. She was going to be having sessions in her house. And we had a protocol where I could text mom if I needed mom to come in the room, or, she had a word that she used if she was feeling a little bit unstable. So we had this all worked out ahead of time, right? So I'm in the process of getting the information from the psychiatrist, but it hasn't come as of the first meeting. So I don't have the complete record or all the meds or anything as verified by the psychiatric part of evaluation. And she proceeded to tell me with a straight face something that was totally psychotic. And, I was happy we had this procedure with the mom, but, I started to pull up online to get in touch with the psychiatrist, and she had signed the document. So it came through my electronic system as signed, but she had not filled out everything in there. And I was like, well, I'll just get through this session, then I'll, clean things up. Wrong move. So, that just reinforced in me that we really, really have to kind of think some part of this out way ahead of that meeting, our first telehealth meeting, especially with these very complex clients, who are, in some cases, fine to see online, but we just need to be able, and actually you know, if you can't see them, sometimes they don't get anything. So, but you have to really, really have that all thought out ahead of the first session. So for me, assessment now begins before the first visit. It's not that I'm doing, you know, the basic full-blown assessment before the first visit. What I'm doing is this a technical fit? Do you have the technical means to do this? And do you understand how to use the technology? Is this a clinical fit? So clinical fit, you know, the literature tells us all kinds of different kinds of patients can do this, and that is fine and very good guidance. The literature has not caught up with the volume we are seeing now. And, you know, again, in our telehealth sessions, the community sessions, we got very, very interesting information. I see somebody that suffers from schizophrenia online. And, you know, I was trained at NAMI. I'm competent in doing that. And my client is doing okay. I have some articles, you know, that have guided me with the online process that are, you know, pretty much if you do the evidence-based work, you're gonna do okay. But this one person in our last telehealth said, yeah, I get that. I totally agree. And, you know, mine has this paranoid part, this paranoid symptom where he thinks that the government is out to get him. And guess what? It has really interrupted, and we can't do it remotely because that interrupts our rapport. Just can't happen. So you got to really think through not just what the literature tells you, but talking through with your clients when you can, but also just thinking through with your clients, you know, thinking through what your clients are like. And then the environmental fit. So, you know, we were talking about the shotgun house. How do we figure out the shotgun house? And so in a session we did last Saturday on telehealth, again, a school social worker, which I think are probably the most resourceful social workers among us, I so respect them, said, well, you know, maybe what we could do is because we do the cases and we break up into groups sometimes when we're doing them, is we could have the session, you know, at the back of the house or the front of the house and have the other entrance be where people go. You know, there were all these interesting ways to think through, but that you would have to think through your client, the guardian with your client, all of these people, you know, how you're going to have that session. And remember, our clients, again, aren't thinking through the HIPAA implications or the interruptions or any of that. And then the developmental fit. You know, there are different types of clients that developmentally are harder to work with online. We had a beautiful example last week of a 3-year-old who actually was in the game and did fine with a little bit of assistance, and they had a system with mom and all of that. Sometimes, you know, and there are protocols around children. Sometimes, you know, ahead of time you set up and you've got to get the consents all signed with mom and all of that, but you set up how that's going to look and who's going to help and when they're in there and what the room's going to be set up and all of that. But then, you know, there are other situations we deal with developmentally that just may not fit as well. So it's not just a question of turning on telehealth and this is the new pioneering way, because sometimes it's not the best fit. So here are some things to consider along that same line. People age 65 and older, more than 41% of Medicare patients lack access to desktop, laptop with high-speed internet connection at home. This is a study done in 2020. People living with a moderate to severe mental health disorders. You know, we talked about my client there. People living with developmental disability. People who are considered low income or living in poverty. Medicaid eligible patients, many times, you know, and we can do Zoom on the phone with them, but we can't have them in rooms with other people. So we have to think through that part of it. People who live in urban or rural settings, people experiencing homelessness, where are we going to find HIPAA compliant places for them? People who are uninsured or undocumented, how do we document where those people are? How do we make sure they're in a safe environment? And along these lines too, is if we have a situation where we suspect abuse or there's just something not right in the house where the client is, how are we going to address that? So here's some more things to consider. Absence of technology or a reliable internet service, which, you know, we've seen the wind blow mine today. And I don't know about you all, but those of you who have shifted to AT&T, I totally get it now because, you know, I'm paying a lot of money for Cox and they aren't always coming through. And there was an article in the Wall Street Journal a couple of weeks ago about the people who are the companies who are going to win post-COVID in terms of cable services are the ones who are going to be much more reliable with connection. There's so many people now working online that it is affecting our service. So lack of digital literacy, if you're unable to comprehend how to use a computer or other digital devices properly, I need to go no further than thinking about my mother who, you know, when we do family Zoom meetings, she literally has somebody from her assisted living center set it up for her because she would no more know how to do that than, and she's a smart woman, a Vassar grad, but she just can't possibly imagine how she would do that. Physical and psychological impairments may bring difficulties in navigating technical devices, hearing aids, all of that needs to be considered. Language barriers. Have a supervisee who's doing a beautiful job with an Afghani family who has a autistic family member, but it's not been easy to do. Inability for a patient to measure the provider's qualifications or level attention during the visit. Again, you know, this may not apply directly to our practice, but it is a concern for us ethically, and the profession is our clients. We need to do a good job of helping them understand what is going to be appropriate for them and what isn't. And there are already people lining up to do Zoom call after Zoom call, coaching, all kinds of things. And our clients aren't necessarily equipped. They might be, but consumer savvy in the difference between some of these providers.
Parker?
Yeah.
We have a question from Rosalie Douglas who wants to know, when in a shotgun home can headphones be used as it relates to privacy?
Totally. You know, I think you still want to not have, you know, unless you're having an assisted session, you still don't want to have people coming in and out of the room. With this case, we're going to see the case later, but you don't want to have people coming in and out that you are not planning to be there. And the people who you have planned to be there, you want to make sure they know their roles. You know, we've heard about cases where there were people that, you know, in New Orleans, we have a lot of kinship care, and there are very complicated family relationships, and some members of the family are safe and some members of the family are not safe. And it's very, you know, to that person. And this person that I'm thinking of right now is ADHD diagnosed, and really it's probably complex trauma that we're looking at. And so, you know, but that's the being inventive and thinking things through in a three-dimensional way, that we're just not flatly thinking through this. So that is something to work toward, sure. Yeah, and so you want to, Luxton was this guy who was kind of involved in the VA system and was talking about this really early on. And I think, as I recall reading, that some of his early writings and experience was involved in developing some standards for telehealth that we're continuing to use and evolve. So he says that safety is the reduction and prevention of adverse reactions or events that might be experienced by patients who partake in care services. This definition extends to the protection of care of providers, collateral persons. So, one of his standards, which aren't explicitly mentioned in the LPC guidance, are, do you know where the firearms are in the house? But, we'll get into that. So this is some of Luxton's initial work back then, is familiarity with civil commitment requirements, as well as duty to warn and protect. I guess I don't have a parentheses around that. But so again, you really need to think that through. So, we were talking about, even in other states, if your client's in another state and something goes awry, you better have thought ahead of time, if you're allowed to do that, what that's going to look like and what that state's duty to warn looks like, and all of that before you have a session, because it's kind of too late when you're in the middle of a session. So these are things that aren't flat anymore. They are very three-dimensional and thought out ahead of time, because all of these state boards, the most important thing, remember, is public safety to these state boards. Any one of them will tell you that's what we're here to do. We're not here to restrict your practice or do these other things. We want you to practice safely and with evidence-based practice. But really, our function is to keep people safe. So you really, really have to think through this. And, he goes so far as to know statutory and case law requirements for telemental health safety planning, and procedures for involuntary hospitalization, as well as requirements for duty to warn by state. Some states do not have statutes or guidelines for exercising duty to protect. Among states that do have statutes, there is considerable variability in the language. So, these are things that we may not have considered when we found ourselves in the position to be working with our clients this way.
All right, Parker, I have one more question for you.
Sure.
This is from Hein Sanchez, or Hyen. I apologize if I mispronounced your name. It says, are there any thoughts or HIPAA concerns when an adult client consents to having a telehealth session with another person in the area or room?
Yes, that is really something that we are struggling. We struggled with this last year when this was first getting started. I have just, clinical connection with a group that practices in Baton Rouge. And, they were doing a couple, which we're going to talk about in a minute. And there are things that need to be considered. So first of all, if you're doing a group online, which people have done, and there is evidence that it works, but if that happens, you've got all kinds of concerns. First, you, just like you would do in a group on ground, you tell everyone, what happens in this room does not go on social media, it is not recorded, any of those things. So, but you don't technically have control over if your client does that, and the board knows that. But you have to make sure that that is definitely in your, your consents. And also, I think we're going to hear a whole lot more about different locations. So the case that we're going to talk about in a minute is a divorcing couple living in two different places, and kind of an escalation event. And so we'll talk about that when we get there. But yes, Very important to consider that. And you know, talk about ahead of time before the session, what's going to happen and what your expectations are. And your expectations are based on, you know, what your licensure is and what you need to happen. And also what your clinical expectations on top of that need to be. So part of the standard operating procedures or specific protocols for handling emergency. And I'm going to show you the simple practice forms on here. And by the way, my liability insurance basically says if you're practicing ethically with evidence-based practices, we don't care if you do telehealth or not. And then incidentally, this year when I renewed, they had a very expensive option to for liability for technology. So I still haven't read it because I've been working super hard, and I've been telling this current group that I'm going to go back and read it before we meet. Maybe I'll do it tonight to see what it really actually covers. But you know, there is a business associates agreement that any of these platforms provide. And many of them say, tough luck, you're on your own. But simple practice does cover confidentiality within the end-to-end encryption. And simple practice is basically bank encryption. And I know I would love to hear, we keep hearing from other people, other ways they've been practicing really, really with other packages and other methods. And so if you guys have more of that, please chime in so everybody gets the benefit of thinking through alternatives. So Carrie, let me know if somebody comes in about that, because that's super cool to be able to think through what might be good for you. You want to determine the appropriateness of the home, appropriateness of the particular treatment. So we have a colleague who is really, really good in EMDR. I think we all know who she is. And she will do EMDR from, I think, the first treatment she'll do online. I'm certified in EMDR, but it's not my whole practice. And I'm just not going to do it online to begin with. I mean, online to begin with. I want to really, if I'm going to do a couple sessions on ground before I move it online. And safety concerns and privacy concerns. One size does not fit all. So again, who is your client? What is your client history? And client history and kind of assessing if this person is good for the fit also includes, what is your client history with other providers? You know, are there cutoffs? Are they working well together? What is the historical story that your client is telling you about prior work? Because that may give you some clues into if this client is really going to be a good fit for online. And discussing treatment goals and pros and cons for telehealth. And the consent form needs to really include all of this. So whatever it is that you've thought through in your policies and procedures and how you're going to do this piece and this discussion with your client, you have the discussion with them, and then you do all the forms. And I'm going to show you some of that coming up. I'm running behind, which I'm so sorry, because I'm going to try and stop at 1:15 so we can get a little bit in about these cases. But where does the client live and with whom? We've talked about this, how to keep them safe. Do you and your client have reliable technology and that you can, and they can detect change in tone and affect? So this is super important because I have a client who has, I don't like to say my client is borderline, but I will say there are certainly some related symptoms. And sometimes he does not detect, or I can't detect in him, and he does a lot of mind reading, and we have to be very careful and clear during telehealth sessions. I usually see him in person. And what is the plan if technology fails? You saw me do that today. I'm really glad we're this far in and we haven't crashed and burned with all this wind. But if you're in the middle of a session and your technology goes down, you've got to have a plan. So my plan usually is, if it goes down, I'm going to text you. I'm going to bring up my personal hotspot and reconnect to Zoom. If that doesn't work, I'm either going to go to my my Zoom platform or my Simple Practice platform online, and then I go FaceTime. And if you know, and I'm texting in between. And if that doesn't work, I'll usually just call the client, reschedule, because that's 10 minutes, you know, to go through that sometimes. It doesn't happen very often, but it's really important that your client understands what's going to happen. Especially, you know, we all see these very vulnerable people, and if they're in the middle of being seen by us, and trauma where people are never seen and never heard, and that's part of the MO of people who are severely traumatized. They don't have voices and they aren't seen, that we make a real effort ahead of time so they know what's going to happen.
All right, Parker, I had one question related to that. It's from Linda Hardy, and she asks, in using telehealth with clients, do you know if AT&T or Cox is better? So I think that falls into the conversation a bit.
Yes. Oh my gosh. I don't know AT&T because I don't have it, but I have heard that I need to come over from the dark side. So I don't know. It's not that my connections are so bad anymore, but I'm paying so much money just to upgrade enough to have decent coverage. And I've heard that AT&T just has better coverage more reasonably. I'm not the expert on this, but I would say it's a really important thing to look into. And I think we'll be looking into it this summer. And somebody else may have a comment about that, because that's how we learned about the AT&T being so good, is in a community that is, you know, really kind of supporting each other through telehealth. Somebody said, oh yeah, Android, AT&T, I'm great. You know, somebody said that, and I don't know where they live. I don't know any of that, but they seem to think that it was really a stellar option.
Yeah, we had a few comments about AT&T, that AT&T high speed is not available in all neighborhoods or areas. So that's a caveat to that.
Yeah. You know, I think that, you know, when we think about it, Cox Cable had a monopoly here. And so for them to hustle and actually be service friendly now that they've got AT&T kind of coming in here, you know, who knows what that dynamic looks like. But then superimposed on that, they have all these people at home now really kind of screaming, what's up? So, you know, and in our particular profession, we're talking about safety for people in treatment. So we definitely have to, you know, think through this and really get closer to what our technology is going to do for us. And also what different kinds of technology we're going to use. You know, the LPC board, which I really love that they're so specific, and I would have brought it in here, but you can see we are running even farther behind than I thought. So they specifically say, and it is a best practice not to do asynchronous work with your client, which means, you know, respond, texting kind of stuff. Check-in is okay, but where are you going to use your technology and what? You know, what's it going to look like? So here are some of the things to think about. And this does come from the LPC guidelines. So adequacy of infrastructure and technology, adequacy of bandwidth, and there is guidance about that. And actually Google measures your connection. You can go to, we can get it for if you want it. It's a place you can go on Google and they will actually measure it for you. Environment, so your lighting, your soundproofing, etc. This is also for your client. It's for you and your client. Adequacy of equipment, quality of computer, cameras and microphones. I have a lot of colleagues who have the cameras that are off of the computer. I do all of my work from my laptop. Backup contact plans, we've talked about that. Tech support procedures. You know, if you're in an agency and you're trying to see clients, you know, how are you going to support them ahead of a first session to see if they really truly meet the tech procedure requirements. Equipment network problems and procedures, troubleshooting. Simple Practice provides a guide for a client. I love it. I like going through it with the client as we're discussing if the mode is a good idea for them. It kind of leads us into discussions about the technical fit before we even get to the clinical fit. I do usually start with the clinical fit, you know, do we think this is a go, and then go to the technical fit. But if one cancels out the other, it doesn't really matter. And discuss technical troubleshooting. So we need a client emergency contact list, which is documented. And this looks, you know, what we have on ground, which is, you know, important, but also EMS, do we have an emergency contact person like I do with my client's mom? And that we not only know where the relevant healthcare and emergency services are, but we also believe that we have a system and that it's not too far away. And you need to talk to your client about who's making calls when, if something goes awry in terms of an emergency. So this is, again, I think directly from the LPC guidance, but site assessments and procedures, obtain patient address and local 911 EMS, provide contact information, obtain alternative patient contact phone numbers, local collaborators. So if, you know, there's a guardian or somebody needs help, who would that person be? And also, do you think that person is a safe person for that person, or is it maybe not the best move? Plan and discuss roles and responsibilities. You also, before you see your client, it's not on here, this isn't part of emergency management, but I know it's not in my slides. If you have not seen your client before, you need to have them give you a form of ID in your first session if you've been kind of working out these assessments ahead of time. Ongoing and follow-up monitoring. Is there, you know, this is no different than on ground. Is there follow-up between meetings? What does that follow-up look like? If you have a rough session or you think something just wasn't quite right with your client, what is that going to be? And is it written into your policies? Documentation and support for yourself. With your particular clients, what do you think is most important to document in general? And for each client, you certainly want to know, you know, specifically if it was a telehealth session or not, and where the client was located, and then regular documentation.
All right, I'm going to
go ahead.
Sorry to interrupt. I'm going to jump in. We had one question from Mindy Malam that says, do you subscribe to Simple Practice Professional and then add on telehealth and use that as your primary platform?
Correct. I like it because, you know, I know everybody's starting to use these platforms or have for a long time. I've been on Simple Practice, I think 4 years now. And to me, it's just, you know, I have a small private practice because obviously I have my hands full at Tulane. And what I like about it is with their telehealth service, first of all, when you're scheduling the client, and I don't allow my clients to schedule themselves, I schedule them, which you can do in Simple Practice. They can come into the portal and schedule their own clients if that's how you work. Schedule their own sessions. But I don't. I schedule them. And when I'm scheduling them, there is a button to click that comes up and says in office, telehealth, or other. And if I click telehealth, it literally will send them the link to that session. And when they do the link on that session, it brings them directly into the portal of the practice system, which is end-to-end encrypted. So when we first had the COVID thing going on last year, what we learned, and I think Zoom has cleaned it up, I'm not exactly sure, but what we learned about Zoom is it's not end-to-end encrypted. And so people were jumping into Zoom sessions. It was always end-to-end encrypted in Simple Practice because they were inside the practice portal. So that is, I love it. This isn't an ad for Simple Practice, but then after you have the session, it literally, you can put your notes in the system and it literally bills the client or insurance, and then the money goes directly into your bank account, your practice bank account. So I see my internet's unstable. Am I back?
Yeah, you're fine.
Okay. I get this little thing on my computer that says internet unstable, so I'm not sure or not.
We did have one question from a few slides back from Dale Robinson Rogers. There was a section that said who's making calls when, and they're curious as to what that means.
So you may have, I'm just giving an example. Depending on an emergency, obviously, who's calling whom. So sometimes you'll be working with a client, and I know people who do this, maybe a guardian and a child, and it's maybe an adolescent or something, and the adolescent will need help or something happens, and so there's an agreement that the adolescent is going to give you a sign and then go get mom. Sometimes, as in my situation with my client, I could get a signal from my client she's not doing well, or I could notice that she's not doing well. And the agreement is both, I'm going to check in with her, but I'm also going to be texting mom to come in the room. So it's just something that you think out ahead of time, depending on what the setup is with that client. And obviously you could have very general ideas about what in theory you're going to do, but you just have to make sure, because remember, we're talking about safety of a specific client by the time we're in a telehealth session. So is that very general policy going to translate for this very specific client is what you want to keep in mind. So again, this is Luxton, monitoring risk. Symptom levels, if they go up and down, again, it's really nice to do some scaling to kind of see where you are. Self-harm ideation, expressed intent to harm others, monitor changes in setting and patient situation. So this is Simple Practice. Wow, we are moving ahead. We're going to have about 5 minutes for the cases, y'all. So we'll move through this. You've got the slides here. But this is literally the client safety plan. Oops, did I go backwards? Which is normal throughout online or on ground. You kind of want to know this anyway, but these are things in between sessions that a client can do. This is kind of like what happens in between. But this is one of their safety plan things. And, for suicide ideation, of course, ending up making the environment safe and what is the most important thing living for. This is the emergency plan, kind of also, if there's an emergency, not to wait for communication back from me, but do one of the following. So you don't have to use this necessarily, but if you've got suicide ideation going on, that they've got a plan next to their bed. And this is something that you can do on and off, being online. This is specific to telehealth. There are additional procedures we need to have in place, and I'm going to read this because I like the way they word some of this. There are additional procedures we need to have in place specific to telehealth services. They are for your safety in case of an emergency and are as follows. You understand that if you are having a suicide or harmful thoughts, basically experiencing psychotic symptoms or in a crisis that we cannot solve remotely, I may determine that you need higher level of care and telehealth services are not appropriate. So I have this conversation with my client and my client's mother as we go, depending on if she's, what's going on with her. I require an emergency contact person and I may contact on your behalf in a life-threatening emergency only. Please enter this person's name and contact information below. Either you and I will verify the contact person, and I like to verify after I get permission from the client because, some clients that I have assume more than a direct conversation. Is willing to be able to go to your location in the event of an emergency. Additionally, if either of you or your emergency contact person or I determine necessary, the ECP agrees to take you to a hospital. Your signature at the end of this documentation indicates that you understand I will only contact this individual in extreme circumstances stated above. So not only are they signing this, but you're having that explicit conversation about why that's important. Then here's the name and phone number. You agree to inform me of the address you are at the beginning of each session. You agree to inform me of the nearest mental health hospital, your primary location that you prefer to go to. And this comes into play with my client who is an hour away. Please list the hospital and contact information. You agree to inform me of the nearest police department. Please list the police department and contact number here. And y'all, I am such a nervous Nelly about this, and I don't know if I'm taking it, a little bit far, but I don't just have that in my system. When I'm seeing the client online now with that particular client and clients like that, I have this form printed out in front of me. So I've got it all there if something goes down. Remember to review with the client, sign that form, review the backup plan in case the connection fails, confirm the phone number on file. You want an alternative number if possible. Inform the client of potential risks and limitations and how, as was in that document, that at some point it may not be a viable option and we'll have to reconsider it. And that's just going to be part of the deal. And that there are alternative non-video therapy options. So again, getting back to the schizophrenic client that has paranoia, this probably isn't where you're going to want to see that client. So what do we have? We've got 5 minutes left. Is that what we have, Carrie?
Yep, 5 minutes.
All right. So we can do this pretty quickly. I mean, ideally what we love to do with these cases, and we kind of bring them up and we split everybody out into groups and we all look at them and come back with what we would think about the case and we all learn from each other. But clearly we've got 5 minutes here. So case one is my client, referred to me early in COVID, and he's post-suicide ideation for outpatient therapy. He had been inpatient for 6 months, y'all. Very isolated, no job, inside his house. He's a cutter. And part of the reason he was referred to me is because I've got the physical setup I have where I could mask and see people in person, and it was a safe environment for that. And so, the only person he was seeing in those early days of COVID was me. And he had no other communication outside of that. He had completely isolated himself from his family, who's not local. He had no job. He had nothing except for his art in his house and a session with somebody. You know, I was his only connection to a live person. And he's an active cutter and really, really fighting and very courageous not to commit suicide. It was hard during that point. He's much better now, but at that point he would tell me about how he imagined the gunmetal would feel in his mouth. It was really difficult, but we made the decision to see. I made the decision, and he really wanted the decision to be that I would see him in person, and I felt it was so important, and I'm glad we did that. So, you know, if you were looking at the literature, they would say, you know, depressed person, totally evidence-based to see a depressed person online. Totally true. But when you take this client into consideration, at least in my practice judgment, it would not have been the best evidence-based work to do with him. So that's taking that very specific client into play as opposed to an academic study of when and when not it is appropriate to use telehealth. Now, this case too is that case about the social worker regarding an ADHD diagnosis in a shotgun house. So we've talked a little bit about that case, and you know, there are people running in and out of the room. The child's having a hard time concentrating. So some of the things that came back, and something that came back in this session that while we're together as a community, is what about the use of headphones? What about the use of, you know, doing some more education with the parents and having the parents work to make sure that, you know, we're using the front entrance or the back entrance, and that the parent is setting up the room. So again, through community, we're helping to figure out these things as we go. And our school social workers that we've been talking to on this front have been telling us this is just, you know, an ongoing issue for them. So, you know, but I think they're getting really savvy at doing the best they can with it. And then case 3 is this case that came out last year when we first started doing the telehealth, and we were about halfway through. And these 2 really super talented couples therapists were talking about this case. They had talked about it earlier. It was one of the therapist's case, and the clients were divorcing. They were in 2 separate houses. She had gone through all the stuff that we had talked about today. You know, and nothing gets disclosed, and, you know, you're in 2 locations, so we need to make sure both locations are HIPAA compliant, and I need to know both of those locations. I need to know both of those phone numbers. Well, what happened was they both got escalated and both got in their cars and started driving and talking to her. And, you know, managing that in the middle of that was like, I mean, it worked out okay. You know, we're short on time, so I can't really go into it here, but it worked out okay. But that is one of the things you need to think through with multiple locations. Could that happen to you? You know? And then it's like, where are they driving? Where's their location? Is everybody safe? You know, that's not the time to be thinking about that. So, you know, as a community, we're learning some things and having some things come up that we never, ever, you know, that we need support with, and we need to think through. And I think the literature and the research is going to catch up. But right now, you know, we've got a lot of supporting to do with each other as we transition again into what are we going to do now that things are loosening up. So those are all my slides, and we're just about out of time. Does anybody have any questions?
We have one person that's raised their hand, and yeah, Deborah, you can go ahead and speak.
Well, I had no questions, but I just wanted to say you did a beautiful job, Parker. Thank you so much.
Oh, Debbie, thank
Can
you.
you hear me? Okay.
Yeah, it means so much coming from you. It really does. Thank you.
Well, in the spirit of protocol, I'm going to have to sign off because I have a client waiting for me. But I have really enjoyed this, and I may want to talk to you a little more about some of the things I do have questions about, but I'll be in touch, okay?
All right, sounds great.
Thank you. Bye-bye.
All right, we have another one from Linda Hardy. Linda, if you want to unmute yourself, you're able to speak.
Hey, Linda.
Linda, are you able to? There you go. Perfect.
I'm here. I hit the raise hand by mistake. I don't have any questions.
Oh, no worries. Okay, great.
Thank you.
You're welcome. You're welcome.
All right.
Let's see, we may have some Q&A. Nope, those have been answered. Oh, wait, I'm sorry. These have not been answered. I'm
Okay.
so sorry. Dale Robinson Rogers again. Best practices for ADHD interventions with clients and parents, guardians.
Mm-hmm. There are things being written on that. And, depending on what your practice is, of course, we like to bring our own clinical voice into that and our own way of doing it. But certainly with ADHD, that room setup is going to be a big deal. The making sure we don't have people coming in and out of that room, making sure any helpers understand their roles in that room, making sure the room is set up with both the helper's role and your client's role, and that both your client and your helper know what's going to happen and who's doing what.
That is all of the questions I see. Christiana, you don't see, oh wait, let's see. Oh, yeah, got it.
No, I just see a lot of thank yous to Parker. So thank you all who have joined us today. Parker, that was an incredible session and I think gave everyone a lot to think about. We will follow up with the recording of this and the slides again. Perfect. And Parker, we can provide your information as well if anybody wants to touch base with you.
I'm happy to provide anything that you guys need in terms of, just any forms that I have or any, whatever you guys need. We're family.
Perfect. Awesome. So thank you all again. We'll be sending out the post-evaluation form. And like I noted in the beginning, I'll be sending out your certificates in the next couple of weeks. So just be a little patient with me while I get those ready for you. And I hope to see you all back here in July with Dr. Samuel Bradley Jr. So have a great day. Have a great weekend. And we'll see you soon.
Bye.